There are some who can't handle it. I mean, I've literally had patients run out into the road and try to jump in front of a moving car or jump out of a window. You can remove a couple and see if they're involved and then make a decision if you need to remove any more. Is it easy? No. I am Dr. حورية. I'm the first Emirati surgeon. I'm actually a breast surgeon, and I am the president and founder of Breast Friends, which is a charity and support group for breast cancer patients. Okay, so first, when I came back to Dubai as an intern, I was working at Rashid Hospital, and that is where I first started seeing really advanced cases of breast cancer. So as I said, I was at that point I wasn't a trained surgeon. I was on a surgical team, and a lot of the women who came in with these advanced breast cancers didn't want the male consultant to examine them or any of the other male members of the team. They would prefer me as, on the lowest rung of the ladder to examine them rather than the male. And then what would happen is I would be on the inside of the curtain with the patient, and then the consultant would be on the other side, and I would have to describe what I saw, what I felt on examination, and then he would say, okay, does she need surgery? And of course, I had no idea. I was an intern at that time. But the thing that really struck me was how advanced these cases are. And if you think about where the breast is on your body, if something is advanced, it's right under your nose, it's right under your eyes, and I couldn't imagine how these women, they must know it's there. It's not hidden in your tummy, you know what I mean? So they know it's there and they still don't or didn't do anything about it. So that was the first kind of inkling I had that what is going on here? Half of it is actually modesty. It's just, we don't want to take our clothes off in front of a male surgeon. The other part is the fear. So because women were presenting late, right, because of the modesty, because they don't want to go to a male surgeon, they leave it until it's so late. And then by the time they do actually go forward because it's so advanced, at this point, the disease is advanced. And most likely these women will then go on to die from it. So in everybody's mind in the community, breast cancer equals death. So this was just building fear in our community. So you had the modesty and then you had this fear. And I thought, okay, well, I can do something about, at least initially, I could do something about the not having a woman surgeon. And it was one of the things that really pushed me, the death of these women who I felt didn't need to die. I'd never seen those advanced cases when I was training in Ireland as a medical student. And I actually had to look up my father's textbooks, so a generation before textbooks, to see pictures like what I was seeing at Rashid Hospital at that time. So those were the things that sort of made me think we really need to have more breast surgeons. And obviously I did like the specialty. It's in terms of, it's much later that I started the support group. So basically I had to leave again. I had to go and do all my surgical training, then subspecialize in surgical oncology, and then in breast surgical oncology, and then finally come back like 10 years later as a trained surgeon. And then I started seeing women, and not just as a surgeon, but I realized, okay, now I've got to raise the national consciousness of this disease. I need to talk to women about it, and because this in our community, we don't even, first of all, we don't say the word breast and we don't say the word cancer, right? You say that disease, or, so-and-so, she has, you make faces and things, and instead of saying it. So, and this culture of silence just breeds more fear, right? Because we're afraid to say it, because if we say it, Bismillah, we're going to get it, right? So, I felt like, okay, this was the other part that I had to do. Yes, I was a surgeon, but now I really had to inform people. And so I went out and I did talks to women's groups, to schools, colleges. Luckily, at the exact same time was when the internet was was blooming. So young people were now getting information, taking it home to their moms and their grandmothers. And so the information was getting out there. The next thing I had to do was to create a space where women felt safe to come. So I started the Well Woman Clinic, and it's only women, it's staffed by women, and it's only for women. And this, we've made the clinic look like a living room. So you feel like you're not in a hospital, and it's not clinical, and it's not scary. Again, trying to take away that fear. So those are the sort of things that, step by step. It wasn't like I had a plan, to be honest, from the beginning, but it was something that as I saw there was a need, I thought, right, if there was something I thought I could do, I'll do it. Yes, so what I did, I realized that as time went, and obviously, I could stand up and give a talk about breast cancer, tell you what to look for, how it's going to be treated. But at this point now, as I said, as the internet was getting there, people could get this information online if they just spent a little time. But what I started doing was taking with me cancer survivors, and especially local cancer survivors, because if you can see someone who looks like you, who has had cancer, but who also has a family, who may have a job as well, and they've done their cancer treatment and they look absolutely normal and life's gone on. And I think that is a powerful message, because the fear, that fear that I said in the beginning, where breast cancer equals death, that's the one that I had to break, that it's not equal to death, that if you pick up breast cancer early, it is more than curable. So this was the message, and for me, I still find to this day that the more powerful message is speaking to people or women who've had cancer. So in terms of screening is a difficult one. So if you look at population screen, so screening means that you're looking for something in someone who is otherwise well. So this is not a woman. If a woman comes in and she has a lump, all the tests we do are diagnostic. This is not screening. Screening is if a woman comes in, she's absolutely fine, but she wants to check that everything is in fact fine. And screening, if you look at population screening, for example, in America, in Europe, in the UK, the age that they start screening, in the US, they advise from the age of 40. In the UK, they do it at the age of 50. Some of that might be because the government's paying for the screening, whereas in the US, you pay, or your third-party payer covers the screen. In Europe, it's about 45 every 2 years, and in the UK, as I said, it's 50 every 3 years. But if you look at, so where did they come up with those ages? If you look at the median age of breast cancer diagnosis in these countries, so North America, Europe, Western Europe, Australia, the median age of diagnosis is 61, 62, 63, so early 60s. So basically, it's a disease of postmenopausal women, an older woman. If you look at the Middle East, so not just the UAE, the whole of the Middle East, North Africa, and the Indian subcontinent, our median age is about 45. So we get breast cancer almost 2 decades younger than the rest of the world. So if your median age of diagnosis is 62 or 63 and you start screening at 40, 45, 50, then that's great, because you're starting, 10 or 15 years younger than than the median age. For us, with our median age of 45, when are we going to start screening? And when I say screening, I mean mammograms for the breast, which are x-rays of the breast. So if our median age is 45, are we going to start at 25? Are we going to start at 30? It's crazy, because when you're young, your breasts are young. Okay? You're still young, so you don't have any perspective. But I'll tell you, when I was younger, my breast looked very different to what it looks like now. And that's because you have more breast tissue. As you get older, it shrinks and it gets replaced by fat. We like fat because the x-rays penetrate very well. We see pictures, we see anything abnormal really clearly if you have fatty breasts. If you have dense breasts, which is normal in young people, though some older people can have dense breasts, the x-rays don't penetrate well. So how are we actually going to screen our young women? Because it is young. Our women are young, and mammograms are not going to pick things up in dense breasts, and mammograms are radiation. And even though it's a small amount of radiation, the effects of radiation is cumulative over your life. So if you start mammogramming people when they're 25 instead of 45, that's a lot of x-rays that you are giving them. So we're kind of stuck as to, from a population point of view, as to what to do. What I do in my own practice is I individualize it. So I take each patient. We actually have algorithms that we can use, equations where we can put in various risk factors that an individual will have. What age she had her first period, did she have children, has she taken hormones, does she have a family history, what her breast looked like on a mammogram. And we calculate a lifetime risk, and we have a cutoff. And anything more than that, we will say, okay, you need mammograms every year. And if it's really high, you might even need an MRI every year in addition to mammograms. So that's what I do in my own practice, but obviously that doesn't work for a population of millions of people. Yeah, I mean, this is something that, you learn to do as you grow up in the field, because a lot of what I do is psychiatry. A lot of, even with patients who don't have cancer, everybody who comes to see me thinks they're dying of cancer, okay? The majority of breast lumps are not cancerous, but of course when somebody has a lump, they don't know that. So my job is to reassure them and make them, be comfortable and confident that I'm telling them, no, this is fine, or no, this is not fine. And yes, and so as you go, like in any job, there's so many different personalities, and you just have to learn how to deal with it. There's some people who are very pragmatic and they want everything straight up. There are some who can't handle it. I mean, I've literally had patients run out into the road and try to jump in front of a moving car or jump out of a window. Had that. And then I've had some that have just said, okay, alhamdulillah, and they just ask for the prayer room, and that's it. So everybody deals with disaster or potential disasters in different ways. And yeah, we learn how to adjust according. Yes, of course. So social history is what we call it. And yes, there are certain things that we know are risk factors. Smoking, not so much, but alcohol, yes. And even one drink is not good. And so it is something that, yes, we can counsel patients on later on, but the one thing that we don't want to give patients is a sense of shame that, okay, well, I drank, therefore I have cancer. Lots of women drink and don't get cancer. It's not as simple as I ate this, therefore I got cancer. Cancer or the start of a cancer is a very complicated thing. It's probably and this is my theory, a combination of a carcinogen, so something like nicotine from cigarettes or alcohol, and the sensitivity of your DNA to that carcinogen. Everybody knows people who've smoked 2 packs a day and they lived till they were 80 or 90 years old, and we all know people who've died of lung cancer when they're in their 40s. So there is obviously a difference. They're still smoking the same cigarettes, but everybody's DNA is different, and the susceptibility of our DNA is different. So yes, we do try to take a history of different risk factors. People talk about stress. Pollution is a big one, because we know that breast cancer is higher. The more developed a country is, the more breast cancer we see. And there is some recent evidence looking at air pollution and breast cancer. But can we do anything about it? I mean, as an individual, no. As a population, probably. But there are things like drinking alcohol we can do something about. Stress is always a very interesting one, because a lot of women, when I see them at diagnosis, have recently gone through a major life event, either a divorce or a bereavement or a loss of job, loss of home. But that age is the age that you expect to go through something like that. So it's really difficult to say, well, you were going through this, therefore you got that. Do you know what I mean? So it's complicated. So when we do a screen, we usually do a screening mammogram. Sometimes we'll add ultrasound. Sometimes we add MRI. And people will ask me, well, which one is best? Well, none of them. The mammogram is probably the best in terms of picking up breast cancer, but it's not 100%. Nothing in medicine is. If you find that you have to do 3 different types of scan for one issue, then none of them are perfect. But they complement each other to give us an almost perfect idea of what's happening in this breast. Then, supposing we find something, well, it depends what we find. If it's a cyst, we don't usually do anything with it unless cyst means a lump with water inside. We don't usually do anything with those. They're harmless. They don't usually turn into cancer. And unless it's large or causing pain or something, we don't do anything with it. If we find a solid lump, because cancers come as a solid lump, well, as I said earlier, the majority of solid lumps are not cancer. So at least 90% of the solid lumps that we see are benign, meaning harmless. They're, what we say, waram leafy or fibrous lumps, and they don't turn into a cancer if they're left. Sometimes we need to reassure ourselves that the lump is fibrous and that we can leave it. And a lot of that, the decision on that will be based on the age of the patient, the family history, if they have a history of breast cancer, what it looks like on the imaging, and then we'll make a decision if it needs a biopsy. Okay, so say we find it as a cancer. Let's kind of move towards the reconstruction. So if you have a lump that's a cancer, I mean, obviously what we tried to do now, up until the mid-70s, everybody with a cancer in the breast had a mastectomy, which means removing the whole breast. Then some very brave surgeons thought, well, if the cancer is only a few millimeters, why are we removing the whole breast? And so they started doing less and less surgery. And we call this a lumpectomy. So if we can do a lumpectomy, most of the time you don't need a full breast reconstruction. Then we do a little bit of kind of, moving tissue around to kind of fill the hole after you remove the lump of a lumpectomy. If a woman needs a mastectomy, which means removing the whole breast, this is when we will offer a reconstruction. And the majority of the time we can do the reconstruction at the same time as the mastectomy. What does that mean? It means we can save the skin, we can save the nipple, because these things most of the time are not involved in the cancer that's inside in the breast. The skin and the nipple is skin. Okay? So what we do is we make small incisions underneath the breast and we remove the breast tissue from inside, but we leave the skin, we leave the nipple. And then at the same time, that hole, under the skin, we fill it with various things. It can be silicone, it can be fat, it can be tissue from the back, from the tummy, to make a new breast, so that when the patient wakes up, they almost look the same, sometimes better. Yeah, so I feel like I'd like to think I was always sensitive to patients and what they were going through, but I am more so. One of the things that actually came that was like a wake up for me was I used to always wonder, in this, as I mentioned, that culture of secrecy that we have, where we don't tell people that we have this illness, where there's so much shame or hiding it because nobody will marry our daughter, or just weird things like that, when we're not afraid to say my cholesterol's high, or I have blood pressure or whatever. And I used to always wonder, why don't patients tell people? Because surely that would be a helpful thing. If I know that you have cancer, I'll think, boy, I better go and have a check, But I realized that when I had it and I started telling my friends, that they would get so upset. They would be crying. I mean, I wasn't crying, but they were. And there was a part of me, especially in the beginning, that was like, I didn't want to upset anyone. And so I would rather not say anything than upset you, because that's not my aim. Yeah, obviously, even if I wanted support, I don't want you to be crying about it, So that was one of the things that I realized, this is why they don't tell everyone, is because they don't want to upset anyone. And same, and as a mother, it was something I had to think about telling my daughters. They were university age. One was in university, one was in high school. So they were old enough to get on the internet and figure it all out. But I wanted to tell them myself, and I wanted them to see that I was fine. I did tell my daughters, definitely. The one I didn't want to tell was my mother, because, again, moms are moms. I'm a mom, so I know nobody wants to know that their daughter has cancer. But I did tell her, and literally she had a cup of coffee in her hand, she dropped it, And so again, I was upsetting people, which wasn't my aim. I just wanted to tell them. Yes, I do tell people to say it, to just tell them. But also I take into consideration their views. Sometimes, their mother might be very old and they just don't want to upset them. And I understand that. Children, to tell your children, I think you should, because I think it's very important to be authentic. But obviously, how you would tell a 5-year-old why mom's losing her hair to how you would tell a teenager is very different, But they're definitely telling rather than hiding makes more sense. And some of the things that I notice, I'll tell you a story about a patient who, when you see very conservative patients, the ones that, when you're taking a history in the clinic and I'm asking them questions, but they defer to their husbands or their fathers or their brothers, So if I say, how old were you when this happened? And then they'll look over and, for the husband to answer, or what meds are you on? And the husband is answering. And what surgery have you had? And the husband is answering. And then this person now has to go through cancer on her own. The husband, father, brother can't do it for her. She has to do all of this. So she's got to do chemo, she's got to do surgery. And when you see that same patient at the end of their journey and the way they march into my clinic and they're so self-confident and they leave the male relative outside and they're so full of confidence because, we forget that cancer has some positive sides. And I've had I can't even tell you how many patients have said to me, I would never wish this on anyone, but I'm so happy I had cancer. Can you imagine somebody saying that? Because it made them think about, it puts perspective on life. The things that we moan about, the traffic on Sheikh Zayed Road or whatever, you realize, that's not, it's in the scheme of things, that's irrelevant. It's not important. What's important is life and love and my family and being there for my family. And so many have said that to me. I'm so happy I've had cancer. To the patients, of course, they know, I see them, I know what they've been through. To the ones, and even for them as well, and to the ones that what we're trying to do is encourage them to be checked. And as women, and I know we can all agree that we are busy people, right? We are working, we have kids, we're always so busy and we put everything and everyone before ourselves. So when we talk about self-care, taking care of your breasts is actually self-care. And it shouldn't just be your breasts. It should be a full body awareness that we take care of ourselves so that we can be around for our kids and our husbands and our parents and the rest of the community. So one of the things that, I think can stir up a bit of fear is this thing of looking for breast cancer or catching it before it catches you, and examining yourself every month and that kind of thing. All those things are actually good, but sometimes it conveys a message of a witch hunt, that I've got to get it before it gets me. And that's not the message. When I tell women that you're more likely to drop dead of a heart attack than to die of breast cancer, they're always surprised. And I tell them, look, and nobody walks around going, oh, my heart, my heart. But, if you say anything about the breast, everybody's so emotional about it. Fine, it's an emotive subject, we get that. But what I like to tell women, look, we've got to take care of ourselves, our whole selves, right? And breasts are just part of that. It's a bit like, wearing a seatbelt. You don't wait till you have an accident in your car to then decide, okay, good idea to wear a seatbelt. We need to be proactive about our health. So part of that is having screening mammograms. Part of that is going for pap smears. Part of that is recognizing when something is wrong with your body, or at least knowing your body so that you'll recognize when something is wrong. If you notice a lump or a bump or a mole that wasn't there, the last time you looked. And, the number of times that I have seen, that I've given talks in companies where women who should be well informed, young people who so they know better, have come up to me and said, I found a lump about 6 months ago. And I'm like, 6 months and you haven't done anything. So as I said, most lumps are not cancer. Check your breasts. If you find something, say something. Don't keep it a secret. And then once you see a specialist, they can sort it out as to whether this is something to worry about or not worry about. And breast cancer, if picked up early, meaning, when we pick it up with screening, is curable. People don't realize that when you sit here we have radiation around us. When you fly, you have a huge amount of radiation, the ambient radiation in the atmosphere. If you fly from Dubai to New York and back, you get a mammogram's worth of radiation. Okay, so you get radiation it's in food, it's in so many different things, so it's not just in mammograms. Obviously, as medical practitioners, not just with mammograms, even with CT scans is radiation. A lot of things that we do is done with ionizing radiation. And as I mentioned earlier, ionizing radiation, the effects of it is cumulative. So each zap that you get is very tiny and is not going to affect, but the effect of multiple times it can have an effect. They've done calculations in terms of mammograms and causing cancer. It's extremely tiny. So it's like anything in life. You could drive on Sheikh Zayed Road and get in an accident. You can drive on Sheikh Zayed Road and you're fine. You have to weigh up the benefits. I need to get to work, therefore I need to drive down that road, which is one of the most dangerous roads in the country. And the same thing with this. I need to pick up cancer early versus, am I hurting myself? The majority, and this is where we get into where I was talking earlier about what age do we start screening? And this is why we don't want to start giving radiation to girls in their 20s. So the answer to the question is, on balance, the benefits of the radiation from a mammogram is way more than the risk of getting a cancer that's caused by a mammogram. And I always tell my patients, if you're so worried about it, stop flying, stop going on holidays, stop getting the radiation when you're up in the air. Another myth that I get is women, when they find a lump, they don't want to do a needle biopsy because you're going to spread it, right? And this one you can actually see. I mean, in your brain, if you think about it, you can visualize, I'm poking this thing and it's going to burst and go everywhere. They've actually looked at this. It doesn't happen. Okay? Cancer is so much more smarter than me or my needle, right? If a cancer wants to spread, it's going to spread. It's not waiting for me to stick a needle in. And the reason for the needle is we get an idea of what this lump is. So number one, if it's not cancer, we don't need to take it out. And if it is cancer, there's some cancers that we don't want to take it out first. We want to give medicines first. So there are many reasons that we do the needle biopsies. It helps, and even if something needs to come out. So say we have in-between lumps, so it's not completely harmless, but it's not a cancer. Different surgery. The surgery to remove a fibrous lump is completely different to the surgery to remove some types of tumors that we have, which is completely different to the surgery to remove a breast cancer. And the needle helps guide that. So we have one operation, which is the finite surgery, right? The other myth that we have is, we sort of touched on it earlier, was that if you have cancer, you have to lose your breast. And that's not true. If a cancer is picked up early, you do not have to lose your breast. And as we mentioned earlier, if you do have to lose your breast, either because the tumor is big or it's in more than one place, or if somebody has a genetic mutation that they've inherited that increases their risk of cancer, those women, we do remove both their breasts. But the majority of time, we can get away with just doing a lumpectomy. Well, it will increase their risk. So remember when I was telling you how I calculate a lifetime risk of a patient? So having first-degree relatives will put your risk up. But having a genetic mutation that you've inherited, that really puts your risk up. So we know a mutation is a mistake in your DNA. We have lots of them. Thankfully, most of those mistakes don't translate into disease, but some of them do. And we know of many mutations that cause different types of cancer. Some of them are breast. And so when we take a family history of who in the family had cancer, it gives us an idea of could there be a mutation in this family? And then we do a blood test that tests for that. Now, if you have a mutation, each of your children has a 50-50 chance of having the same mutation, and so on. But I think where we're going with genetics is amazing, because I think it's a good thing. Number one, it helps me as the doctor to know how to screen you. So if you have a mutation, even if you've had breast cancer, it means your risk of another one may be high. It means your risk of maybe ovarian cancer or colon cancer may be high. So I know that I need to screen you more than the average person that's out there. And then with the kids, say you haven't had children, but you want to have kids and you know you have a mutation, you can actually go to an IVF center, a fertility center, and they can choose the egg or the sperm that doesn't have the mutation. So basically you do a test tube baby without the mutation. So we call this pre-implantation diagnosis. So before we put the embryo, we check to make sure this one doesn't have the mutation. No, this is so if stage 1 breast cancer, what that means is cancer, that's just, if the breast cancer is just confined to the breast, it hasn't gone to the lymph nodes or anywhere else. So that's called stage 1. And stage 1 breast cancer has a life, your life expectancy is in the 90%. So it's almost cured, basically. One of the interesting things when it comes to reconstruction is you assume that every woman wants a reconstruction. No, but if you remove the whole breast, you would think, oh, of course, every woman would want it. And I'm always amazed. It has nothing to do with age. I have several women in their 30s who absolutely refused a reconstruction. They're so happy to be flat. And I've had a 75-year-old woman that was very upset at me for not offering her a reconstruction, and she was a very active swimmer, and she didn't want to deal with using a prosthesis in her bathing suit. So everybody is so different when it comes to what they want and how they see themselves. So people ask me, well, what would you do? And I'm like, well, your breasts are actually for feeding the baby. It's literally to give life to the baby. My kids are 22. If somebody said to me now, I need to cut off your breast, take it, right? If they said my eyes or my leg, no, I need these every day, right? But most women don't think like that. A lot of women will say, no, but this is me, it's part of me. And a lot of women, their entire feminine being stems from their breasts. And I've actually had women ask me, how many grams of breast tissue am I removing? That's how attached they are to their breasts. So some of the newer things that we're trying, one is in the actual detection of cancer. And there's a lot being said about AI. You remember I was talking about about mammograms, which are x-rays of the breast. And if your breasts are dense, it's easy to actually miss something that's going on. But with the inclusion of AI, we're finding that the pickup rate is actually better than the human pickup rate. So this is something that's actually quite exciting, where basically what AI does is it looks at patterns and tries to predict where and who is going to get something. Some of the other things that we're doing is, and this may be a surprise, is we're actually trying to de-escalate treatment. We're trying to do less, not more. Whether it's in surgery, whether it's in chemo, radiation. So for example, with surgery, we're realizing, when I first started training, as I said, everybody used to get mastectomies. We would remove all the lymph nodes from under the arm. Now we don't necessarily do that. We know that it's not necessary to remove a breast, and it's not necessary to remove all the lymph nodes. You can remove a couple and see if they're involved, and then make a decision if you need to remove any more. With chemotherapy now, we are using less chemo. We are using, as I mentioned earlier, targeted therapy, where we're trying to look for any kind of focus on the cancer cell itself, that we can produce medicines that target those foci. In radiation now, I don't know if you know, but after we do lumpectomy, so if we save the breast, where we have to radiate the residual breast tissue. What does that mean? So initially everybody just removed the breast tissue, and up to the 1970s, when they started doing lumpectomies, they realized that the local recurrence of cancer was high. So then they decided to radiate the rest of the breast tissue, and they realized that the local recurrence rate was almost the same as a mastectomy. So basically, you could do, this is why we can offer patients the choice sometimes of having a lumpectomy versus having a mastectomy. But the radiation is given every day, 5 days a week for 5 to 6 weeks. So it's a lot. But right now we are doing what's called, we're not doing it here yet, but this is one of the things that we're looking at, is doing radiation at the time of surgery. So you remove the lump, you do the lumpectomy, and into that hole, you put a probe and you give the radiation, 40 minutes, everybody leaves the room, 40 minutes, it's over. One of the, I think, the hardest parts of the treatment of breast cancer. So when we talk about treatment of breast cancer, we talk about surgery, chemotherapy, radiation therapy, hormone therapy, immunotherapy. There are all kinds of things that we use. But I think the one that everybody is most scared of is chemotherapy. And the biggest thing they're worried about is losing their hair. You know, as women, especially in this part of the world, you know, our hair is like a big part of how we consider ourselves women, and where beauty, part of our beauty, comes from. And the good news is that we now have special cold caps. It's good news. It's sort of good and not so good. So the good news is we have these cold caps that you can wear. It's literally like having ice on your head for hours, that stops your hair falling, or only a little bit will fall. So I have women that have gone through, 5-6 months of chemo, and they have a full head of hair. Is it easy? No. I mean, imagine putting ice on your head and just leaving it there. So it's not, some patients have even said to me that was worse than the chemo itself. But we have options. So we're getting there. And some of the treatment that we give now, so chemotherapy, just to explain, is a medicine that kills cells that are dividing. Okay? And that's why our hair falls, because our hair is dividing, it's growing all the time, right? So every day our hair is growing because those cells are dividing. So that's why the chemotherapy kills cells that are in a growth phase. Thankfully, it doesn't kill our eyeball, because our eyeballs don't grow, so our eyeballs don't fall out, but our hair does. And it's the same. So when the chemotherapy is given, it doesn't know which is a cancer cell and which is a hair follicle cell. But we now are getting so good at finding what we call targeted therapy. So we're starting to look for things that are actually on the tumor cell and have medicines that kill that, or are attracted to that particular protein on that cell, on a cancer cell. So we're getting there, and the side effect of that is probably going to be less hair fall. My patients inspire me every day. As I said, we talk about women being strong, but I see it every day.